This topic is compartment syndrome. There are numerous fascial compartments in the upper and lower extremities, and these compartments are comprised of muscle and nerve fibers surrounded by layers of fascia. Compartment syndrome is a limb-threatening condition that occurs when one or more of these compartments undergoes significant pressure. This can happen one of two ways. The first way is from an increase in internal pressure that occurs from things like bleeding or edema. And the second way is due to a decrease in compartment size from external pressure. This can happen from restrictive dressings or casts that are too tight. Regardless of whether pressure increases internally or externally, increased swelling leads to compression of the arteries and nerves, as we can see here on the image on this slide. Decreased blood flow through these compressed vessels can lead to tissue ischemia and impaired nerve function, which can result in the loss of a limb or limb function. Risk factors include any condition that causes swelling or constriction of the extremity. Burns are unique in that they have two mechanisms that can lead to compartment syndrome. First, burns can lead to third spacing, which is significant edema that occurs internally. And second, burns can cause the external skin to become thick and fibrotic. This eschar is non-pliable and restricts underlying tissues from expanding. Musculoskeletal injuries, like fractures or crush injuries leading to muscle destruction, can cause significant internal hemorrhage and swelling. Casts and splints that are too tight restrict blood flow back to the heart. Revascularization surgery increases the risk for reperfusion injury. Essentially, if an extremity has had limited blood flow due to obstruction, and then we suddenly reperfuse that tissue, this can lead to that part of the body not being able to accommodate that sudden rush of blood, which can contribute to the development of compartment syndrome. Snake bites produce potent toxins that can contribute to the development of tissue necrosis and swelling, and massive IV infiltration is also a risk factor. The image on the right of this slide is a great representation of the different compartments of the lower leg. As we can see, different muscle groups are separated from one another by different groups of fascia. It is very important to recognize symptoms of compartment syndrome as quickly as possible to prevent or minimize damage to the affected area. One way to remember the symptoms of compartment syndrome is to remember the 7 Ps. The first 4 Ps are generally considered early signs and include paresthesias, such as tingling, numbness, and burning. Pain, especially pain that's unrelieved by medication. Even if the patient receives an opioid, they may immediately be calling the nurse again to receive more pain medication due to such an unbelievable amount of pain. Pallor, meaning paleness, and pressure, meaning that the skin appears taut or the client is reporting that a cast or dressing is fitting too tightly. The last 3 Ps are considered late signs and could mean that the limb has already lost function. These last 3 Ps include pulselessness, poikilothermia, which means the limb is cold to touch, and paralysis of the limb. Complications occur from lack of blood flow and nerve damage. The client may need limb amputation if there is a significant amount of ischemia and necrosis that have occurred. If compartment syndrome affects an upper extremity, we may see the development of Volkmann contracture, which is depicted on this slide. The client may also suffer irreversible nerve damage and long-term persistent weakness in the affected limb or complete loss of limb function. When compartment syndrome is recognized, the nurse should immediately place the affected extremity at the level of the heart. If we elevate the extremity, this may help a little bit with blood return back to the heart. However, this can affect overall perfusion to that extremity. In contrast, if we lower the limb, this can help with perfusion. However, it slows blood return back to the heart. Therefore, it's best that we keep the limb at the level of the heart. If the client has a cast or dressing on that extremity, it should be removed immediately. And we may need to prepare the client for a possible emergency fasciotomy, which is a surgical procedure that uses an incision to help relieve pressure. Following fasciotomy, the nurse should monitor for signs of infection at the exposed surgical site, check for return of perfusion by monitoring capillary refill to make sure it's less than 2 seconds, as well as assess bilateral pulses. We want to assess both pulses to check for any deficits that may be present in the affected extremity. And the nurse should help the client perform range of motion exercises to prevent contractures and maintain limb function.